There you go. We're on page 491 with part 4 of the peripheral nervous system, and we're dealing with regeneration. Damage to nerve tissue, it says here, is serious because, as a rule, mature neurons do not divide, so we're not going to get replication. Of course, this is based on age, and of course, when you're born with only 1/3 of a cortex. One of my students has told me that on the way home from the hospital with her brand new child, they had a very terrible car accident and brain injury was profound in her, a little girl, but that the neuroplasticity at that time of life was such that her little girl ended up becoming a fairly well-adapted and normal girl after some time, despite the brain damage and resection that was required. So you have 2/3 of your brain yet to lay down at the age of birth, right? And so there's possibilities, shall we say. Okay, in the peripheral nervous system, we have something called Wallerian degeneration, which leads to a neural sprouting. We have to take a look at that. So it's listed here in terms of the steps that are necessary for it to take. They don't use the term Wallerian. It's something that the current textbooks stopped using. Oh, no, it's right there. Look at it. Except that they forgot the umlaut over the A. The first A is supposed to be Wallerian. But anyways, the axon fragments and then the macrophage will clean up. This is easier to see with the visual presentation. Let's take a quick look here at the peripheral. Now this is peripheral, and I want to just come over here for a second and mention to you that central nervous system fibers, it says here, never regenerate. At least that's the consideration or the thoughts at this time. Consequently, damage to the brain or spinal cord, it says here, have been viewed as irreversible. Okay, but of course, as I mentioned to you, the central nervous system is quite plastic at certain ages, under the age of 5. So there are possibilities, shall we say. But at any rate, once you get past that, a certain age, the neuroplasticity is not quite so good. Alrighty, so then here we have an injury to the nerve. Now, in this situation and under these conditions, you can get regeneration. Why, you might ask, is because these cells out here on the edge, do you see that right there? There's a cell nucleus right there, and this cell right here. So these are Schwann cells, and as long as those are still in place, then what happens here is you can see that the nerve actually turns into fluid of a certain kind, fat fragmented axons. It's kind of really oil droplets, and then there's the sort of like watery droplets over here, and then we get degeneration going down this way, and so the oil droplets proceed. Now there's going to be Schwann cells that, as you can see, are going to create a little bridge here and sort of cordon off what's gone on, and so the nerve is ending right there, and that we're going to get a degeneration, how shall I say, distal to that, and through the use of macrophages, we're going to clean all of that up inside of the Schwann cell. We're not going to disturb the Schwann cells. So you have to be, crazy lucky to have an injury of this type where the Schwann cells are still intact and in place. Okay, and then because we have Schwann cells intact and in place, then we have these little fine axon sprouts or filaments that will grow quickly through this area here, and we'll get a full-on regeneration of the single enlarging axon filament. Okay, so, and again, it's because the axons are in place. If there is disturbance of any kind, then of course this could grow in any way possible. It might not meet up with the muscle or with the receptor, depending on if this is a receptor fiber or if it's a neuromuscular type of fiber, okay, leading to a neuromuscular junction. So at any rate, it will grow back, but only if these sort of like little gatekeepers here, the Schwann cells, are still intact. It will grow to some degree under any conditions, even if there's a complete amputation, but it will grow kind of wildly at the very end, and then whatever it is that you've associated with this in your brain, either by motor means or by sensory means, somatosensory, you will still have that part that's missing, but it will the patient will feel that part, okay, and because the nerve is still there. So normally I have people tap their funny bone, which is the medial aspect. If you go over to your medial malleolus of the arm, and right there by the elbow, and just sort of tap underneath the medial malleolus, there is a groove there that has the ulnar nerve, and it makes your little fingers tingle, except that your fingers are not tingling, it's your brain that's tingling. Just a little detail, because the action potentials are moving toward the brain, not toward the fingers. So you're tapping your elbow and you're feeling your fingers, kind of an interesting little detail. You know, you sort of like, you can sometimes smack your elbow a little hard and you get that tingly feeling in your fifth and fourth fingers. And you think to yourself, ooh, my fingers are tingling. No, it's the nerve that's tingling. But we can go over that at some time in more detail. Meanwhile, we're going to be dealing now with cranial nerves, because we're in the peripheral nervous system and we have cranial and spinal nerves. Let's get a big overview here. If we were to look at the, how shall I say, the ventral and also inferior aspect of the brain, then we would see, first of all, we would see the pons right here, which is encircled by cranial nerves. So as we go anterior to and superior to the pons, you can see cranial nerve number 1, looks like little antennae there. That's the olfactory. We have the next nerve, which is the optic nerve, and it goes through the optic canal. And then we have cranial nerve 3, which is the oculomotor nerve right there, and it serves the extraocular muscles of the eye, 4 out of the 6. It also takes care of parasympathetic function in the eye, so things like contraction of the pupil, okay, or constriction of the pupil, and then there's also some other little details, fluid flow and all that kind of stuff. So very parasympathetic. Then we have number 4 here, which is the trochlear nerve, and it takes care of movement of the eye down and out, taking care of the superior oblique muscle of the extraocular eye, outside the eye. Okay, so that's 4, and then 5. Look how big 5 is. 5. It's trigeminal, which is a triplet. Okay, Gemini means twin, but it's a trigeminal, so it's a triplet. And cranial nerve 5 has 3 branches that we've been learning about in prior times. Remember, we have the ophthalmic going through the superior orbital fissure, and then we have the maxillary going through the foramen rotundum, and we have the mandibular going through the foramen ovale and down into the jaw. Okay, so trigeminal, ophthalmic, maxillary, mandibular, 3 branches. Then from 5 we come over here at the very bottom when we have number 6, and that's abducens nerve right there. And it goes into the superior orbital fissure to serve the eye's lateral rectus, so that we can look directly to the left or to the right, scanning the horizon. And then we have 7 and 8 down here at the bottom. 7 is facial, 8 Of course, they're going to have that over here, I suppose. Yeah, there's 8 over here, 7 and 8, facial and vestibulocochlear is 8. And then we have 9, 10, and 11 in the post-olivary sulcus, and we have 12 in the pre-olivary sulcus. And there's the olive right there. At the bottom of the olive, we finish with the medulla, and we start, actually, the spinal cord. Okay, and look at that, we have a pyramidal decussation, just the way you like it.